Hi, everyone. Apologies for our delay in starting just a few minutes late. I'm going to give it a moment while everyone is connecting to audio here. Apologies again about the delay. Welcome, everyone. Thank you so much again for being here. My name is Brooke Akins, and on behalf of Q1 Productions and LexisNexis Risk Solutions, I'd like to welcome you to today's webinar and thank you for joining us. Today's webinar will discuss secure and compliant patient data management through tokenization. And we'd like to thank again our sponsor for developing today's content, LexisNexis Risk Solutions. We're very lucky to have Emily Mortimer, who's the Director of Strategy at LexisNexis Risk Solutions, with us today. And she'll be speaking to the need for patient-centric tokenization in healthcare. She'll also be exploring the differences between de-identification, pseudonymization, and tokenization, and finally provide you with a greater understanding of the use of tokenized data to solve outcomes and efficacy challenges. A few brief notes about today's sponsor. Again, LexisNexis Risk Solutions is passionate about leveraging data and analytics to connect healthcare organizations and the patients they serve in meaningful ways. By applying proprietary technology and advanced analytics to rich data, they deliver actionable insights to healthcare clients to empower informed decisions, helping to ensure compliance, improve financial results, and support better health outcomes. Headquartered near Atlanta, Georgia, LexisNexis has offices throughout the world and are part of Relix, a global provider of information-based analytics and decision tools for professional and business customers. Thank you again to Emily and LexisNexis Risk Solutions for developing today's content. To all of our attendees, please note that a copy of the recording will be sent to all registered attendees upon completion of today's webinar. There will be an opportunity to get your questions answered by Emily, and you can submit those questions and comments at any time during the presentation via the Q&A option that is on the bottom of your screen in your Zoom toolbar. I do encourage you to be as specific as possible when submitting questions and comments. Please feel free to include an example or reference back to a particular area within the presentation to better assist Emily in thoroughly answering your questions. Again, feel free to submit questions and comments at any time via the Q&A option in the Zoom toolbar. But without further ado, I'd like to introduce our featured speaker today, Emily Mortimer. Emily is the Director of Strategy with responsibilities for strategy and development activities for LexisNexis Social Determinants of Health Solutions. In over 8 years at LexisNexis, Emily has served as the subject matter expert for medical claims and analytical solutions, holding roles leading client services and implementation, managing analytics and statistical modeling resources, and finally contributing to product management and strategy. Emily has a background in public health epidemiology, holding an MPH from Drexel University School of Public Health. I'd now like to welcome and hand it over to our presenter, Emily Mortimer. Emily, I think I've got you muted, and whenever you're ready, please feel free to start.
Absolutely. Thank you, Brooke, so much for that great introduction. And thanks everyone for joining us this afternoon. I know everyone has lots of demands on their time, so we really appreciate you joining us today. So since Brooke already did a great job of introducing both myself and our organization, I'll just kind of hop right into it. So today we want to talk a little bit about sort of an introduction to tokenization. And just by way of warning, prior to getting my master's of public health, I actually have a history background in my undergraduate degree. So when I started down the rabbit hole here, I thought I found some interesting tidbits that I'm going to pull forward into this conversation, and I hope you all bear with me through that. But we'll also talk a little bit about sort of, understanding kind of the key terms in the industry, understanding the differences in terms of both kind of how they're applied and what they mean, and specifically why they matter, right? So talking about the legislation that's often driving some of these initiatives, and then getting into really what is happening in the current state of the industry and the technology, what the kind of primary drivers are for businesses in their need for these type of data solutions, and some kind of best practices to take forward in your business planning. So I wanted to start by sharing in the registration information, we requested that everyone supply their assessment of kind of how deep their understanding is with regard to data tokenization. And I should warn you, I've taken a few liberties here to create groupings that would be meaningful to share, but really categorizing our audience and the experience that they hold. So what this tells me, with about half of our audience kind of identifying themselves as beginners in this space, there are probably a lot of people out there who are hearing about this in the industry and kind of asking themselves similar questions to what I was asking, honestly, to understand what is tokenization? How does it apply to my business, or in the case of LexisNexis, to our customers' business? And kind of how can this relate back to the decisions that I'm making? When I look at the 55% or so of our audience that's in the intermediate or advanced category, this tells me there's probably a couple of people out there who would be better positioned from a maybe technical or detail and history of what they've been working on with regard to tokenization to potentially give this presentation and have an even more detailed understanding than what I have. So I'm going to appreciate kind of all of you if you have questions or comments. I think we really value your expertise and understanding in this regard. So thank you for joining our conversation today. So as noted, I kind of went about trying to understand the technological introduction of tokenization, and in that process went down a little bit of a rabbit hole, but one that I think is kind of interesting and applicable to what we're going to talk about today. So consider tokens and their use historically, as really anything kind of representing the value of something else. So coins as minted today are obviously an example of this. The coin in and of itself does not have that value in gold intentionally, but it represents a value, and it represents a value that we kind of, as a culture and as a society, wind up agreeing on the mutual definition of that value. So I think it's an interesting kind of visual or kind of corollary to what we're experiencing in tokenization as we talk about the technical details here. But on a little bit more of the rabbit hole side, kind of getting into ways in which tokens were maybe used in an unexpected way throughout history, specifically things like subway tokens or Israeli phone tokens pictured here. I just sort of found some interesting discussions of the ways in which those wound up being used during times of inflation, because they held the value to the user in a different way than the dollar did, right? So you could have a subway token purchased for 50 cents, and that still gave you one subway ride, even as the dollar lost its value and you needed to put more of your money toward the purchase of a new subway token. So I think that's sort of an interesting example of what's happened throughout history. And lastly, having just returned from a week in Las Vegas for HIMSS, had to mention the casino chip, right? So consider a situation in which a token or a chip holds its value really only within a certain set of circumstances. I couldn't take a chip off of the casino floor and bring it back with me in my pocket to Minnesota and expect that it would have the same value to anyone here that it does in that situation. And I think that's another good kind of corollary for the way that tokens tend to be used, technologically speaking, sort of understanding the context in which it is used and the value that it holds within that context. But back to the original question, right? I set out to better understand sort of where did tokenization from a data security and data information perspective originate. And really here we find a lot of origins in the financial industry. So understanding that the exchange of information, highly sensitive payment information, it was kind of happening with a high level of frequency with credit card processing. And also, in a situation in which it demanded high speed of transit, so couldn't sacrifice speed in order to maintain a high level of security. Tokenization was sort of introduced in that space to enable authentication and verification of information while protecting personal information as well. As noted above here, really, tokenization can be any process by which sensitive information is replaced by a surrogate value or a unique identification symbol. So I say that here, but obviously when we think about healthcare data tokenization, we typically are thinking about a process that will protect the identity of the individual patient without obscuring or devaluing all of the information about their medical or clinical experience. And I think that's kind of an important context, again, to be considering when we're thinking about tokenization within healthcare. So getting into sort of why tokenization matters for healthcare, or data security for that matter. I would be remiss if I didn't start by mentioning HIPAA, or the Health Insurance Portability and Accountability Act. As I'm sure you are all familiar with, HIPAA really mandates a number of things within healthcare. Important legislation that covers things from the ability to move your doctor and take your records with you. But I think the piece of HIPAA that's been the most impactful in the industry of healthcare data is the mandate around de-identification. So the legislation really lays out who can be defined as a covered entity with rights to protected health data, who can be identified as a business associate of those covered entities and the types of kind of interactions that would be allowed in those circumstances. And then what are the policies for sharing data with entities that don't fall under one of those umbrellas? And that's where a lot of the de-identification comes into play. And we'll talk in a little bit more detail about what those approaches are, but I'm sure you're all have passingly at least heard about safe harbor and expert determination, which are kind of the key takeaways from that particular de-identification component. The other point I want to make about HIPAA is really thinking about the incentives and what that has kind of driven the industry toward as it relates to complying with legislation. A lot of the penalties associated with HIPAA are really focused on data breaches or a situation in which you are not correctly and comprehensively protecting that information on an individual. So they really put all of the incentives on an organization to limit their risk of exposure, limit the risk of data sharing, even in a situation in which that means that they might share less data than they are legally allowed to share. So I think that's a really interesting kind of mentality to be thinking about, right? Is what does that do to the industry when they're thinking, how do I protect myself against that risk? And that's going to be driving a certain set of behaviors. As we move into kind of more current legislation, the 21st Century Cures Act, which was passed 5 years ago, but was really just kind of hitting its stride with different implementation and rollout dates passing this year and over the next 2 years or so, we start to see a focus on a slightly different shift as it relates to the incentives on the organizations at hand. So the interoperability section specifically of the 21st Century Cures Act is driving toward improving data sharing, improving the ability of patients, their providers, their payers, really anyone who is operating on a patient's behalf to access information and complete information on that patient. It's creating kind of pathways and portals that make that data sharing easier and more consistent. And again, thinking about the mentality of the industry, it creates the opportunity to shift the mentality. Now, instead of only looking at penalties that would really kind of come into effect if you shared too much data or overly sensitive data, you now also have penalties that say, if a patient's data is inaccessible, you could be penalized for that. If a patient's data is transferred and it's incomplete because records were disconnected, that could incur its own penalties. So it's going to force a little bit of a mindset shift of saying kind of how can we achieve the goals of the 21st Century Cures Act, of the interoperability standards, with a focus on complete, comprehensive, accessible data, and doing so without any violations under HIPAA. So I think we're all still sort of seeing exactly how that mentality shift plays out within the industry, but it's a really good opportunity to create some kind of traction with improved data sharing. The last notes here are not specific to healthcare, but I wanted to kind of point them out. So in the US, we typically see that our data sharing and data protection and privacy rules are governed by kind of a patchwork quilt of legislation. It can be different at the federal level versus the state level, municipal level. And we also have different policies applying to different types of data. So obviously we just described healthcare data specifically, but there's also federal level legislation for things like driver's license information. There's federal level legislation for protection of children's data information, children's online privacy. And then a lot of other protections happen at the local or state level. In the EU and the UK, there are national, and in the case of the EU, international policies in place that protect data protection and consumer rights. And consumer rights are not exactly the same thing as patient rights, but it is something that I think is going to be relatively impactful in terms of considering kind of responsibilities for things like data storage, restoration, transparency, all of that kind of stuff. And as it relates to that, state level legislation like the California Consumer Protection Act, CCPA, and some other state policies are really doing similar work to drive policy at the state level over consumer data and data sharing. But getting back into HIPAA in a little bit more detail, as we look at the de-identification provisions under HIPAA, the two kind of approved methods of de-identification, which enables data sharing outside of the covered entity and BAA umbrella, are considered safe harbor and expert determination. And I think the way to think about this is safe harbor tends to focus on removal of specific and sensitive information that could include kind of modification or generalization of the data. So, one of the examples here is taking a full date of birth and obscuring it to a year of birth. But with the intent that you are left with a data set that is, general enough that the risk of re-identification is very low. The unfortunate consequence of that can be that it is also general enough that it doesn't support use cases that are very specific and tied toward really understanding how to track a patient over time, look at their specific outcomes and things like that. On the expert determination side, the risk assessment is tied to kind of a thorough review of both the contents of the data and the context in which that data will be used. And that can include understanding, what really is the reason that the data elements are necessary, what types of analytical questions will be asked of the data in the investigation, what other data assets will be used in combination with the data set. And all of that is evaluated by an expert in the field, typically a statistician or a data scientist, to understand the risk of re-identification of the data given in that context. When an expert determination is complete, you typically are left with a document that confirms that based on the methods and the results enacted, risk of re-identification of a patient within that data set is substantially low, such that the data can be released in its form. So that might include things like shielding of something that's publicly available if it was in a public record, for instance, but would allow you to report on, say, a patient's diagnosis and the date of a specific procedure. So just another note here on the risk of re-identification. Specifically, you'll hear people talking in the industry about kind of how to assess re-identification risk. And I think, in conversations that I have had with folks in the business and even more technical folks, it often gets confusing to understand the difference between what is, an obvious risk of re-identification and what yields a risk but may not be immediately obvious to the end user. So clearly, I think we all understand that like a name, a full address, a social security number is something we would be considered an identifier under expert determination under HIPAA. And it's clear to all of us why that would be a risk to re-identify a person. But that can also include more industry-specific things. So consider, a patient control number or a member enrollment number from a payer, things like that that are maybe not publicly available, but still have a pretty kind of consistent and universal meaning. The other thing to note really is a section of information considered quasi-identifiers. And in this space, I think I've run into a number of conversations where individuals seem confused as to why this would be something that would tie to a risk of re-identification. But it can be something like age or the geographic zip code in which you live, or something like a job title. And the idea here really tends to center around the fact that, in any given population, some of these things could occur rarely enough that in combination, they allow for triangulation of a patient record. The last note I wanted to make really here on considering kind of the legislation and then also some of the kind of keywords is that we talk a lot in healthcare about de-identification. But as you get into the space of data security, there's a lot of other terms that are highly important to processes that protect and preserve data and security that can be related to, but not necessarily, exactly the same as or integrated into a process around de-identification or tokenization. And I really just bring this up because I think this is an area where there can be confusion if you're kind of coming into a technical conversation as a business stakeholder. So, you can consider approaches that are supported in parallel to create a holistic, data security and sensitivity management program, but that are not necessarily specific to tokenization or de-identification. I think one particular note is that tokenization within healthcare, I think, is used a certain way, but it is worth noting that tokenization in and of itself is not necessarily an expert determined de-identification approach. So you could put a token on a row of data that still retains a risk of re-identification if you haven't gone through thorough de-identification processes. And that gets back to the prior slide and the comments about quasi-identifiers. Really, it takes an understanding of how those different attributes can be used in combination to assess the risk related to re-identification. I also wanted to note here around kind of anonymization. So this is another word that I hear thrown around a lot, and it also is not, the same thing as de-identification. Anonymization can cover different techniques that I'll mention on the next slide, but it's not necessarily something that has been statistically validated or confirmed as protecting against individual re-identification. And then finally, on the left-hand side, you see encryption. So really here, this could be encryption, this could be hashing, this could be a cryptographic technique, but this is intended to kind of encapsulate a set of data science and kind of engineering principles around protection of data at rest and in transit. And these are theories that are applied to tokenization techniques, but they are not necessarily only applied in those cases. So it's worth considering sort of how these things can be used in conjunction. And you might have someone at your organization who is, in the infosec side of the business, who's really going to be an expert at something like encryption, but who doesn't inherently come to the table with deep knowledge of de-identification because that's such a niche area. And then just a moment on the data anonymization techniques I mentioned before. So noting that there are a lot of business opportunities not specific to healthcare in which reducing risk of sensitive information isn't necessarily tied to legislation like HIPAA, but it could just be that the more people that have access to sensitive information, the higher your risk of hack or data breach, or really any kind of security issue becomes. So you'll see certain organizations putting in place data masking or data generalization techniques, basically any technique that says, unless you truly need this information, let's come up with another way to display it so that the only people who access the most sensitive information are those who have a need for it. So in an example for the first one here, data masking, this is a pretty elementary cryptographic tool of saying, assigning a number to each letter of the alphabet. Maybe this would be displayed on an interface, when someone did a query for a set of records, not because you couldn't drill down into the records, but just so that anyone walking by your monitor doesn't have access to that really sensitive information. On the data generalization side, you can see this is kind of similar to what typically happens within Safe Harbor, basically taking specific data elements and rolling them up to a level at which they are meaningful, but much more general. This can support, high level, say cohort or other high level analysis, but likely not going to be used in really specific deep dive analyses. So a different method that could be deployed there might be something like pseudonymization. So take a record and replace it with a different name, a different zip code, a different date of birth, but enable someone to kind of preserve statistical accuracy and data integrity and drive efforts like development of models, training of models, testing and analytics, while protecting the privacy of the individual. So with any of these techniques, really the question to typically ask is, what is the use of the data and what exact information needs to be retained in order for the data to be useful in that circumstance? So to that end, I want to start getting into more specifics related to healthcare. So what exactly do healthcare users need to do with data, and why is it that these questions are so important? And Brooke, at this time, we wanted to get the team or get the audience to interact for a moment and respond to a polling question here.
That is correct, Emily. So I'm going to launch the poll right now. You'll see the question there, and want to give everyone time to respond. We're asking who at your organization, which teams, departments, or so forth are working with tokenized data. You can choose more than one option, and I'm going to keep this open for the next 20 seconds or so. I see some responses coming in that we're, of course, going to share with the group as well. But again, curious to know who at your organization, what teams, departments, or so forth are working with tokenized data. If you do choose the other option, feel free to enter that specific department within the chat. You'll see the chat on the bottom of your Zoom toolbar. Very curious to get your feedback there. I see we've got about 70% of our attendees responding, and I give you guys just a few more seconds to respond back. Thank you again for everyone who's participating. And again, options are real world data, outcomes research, clinical trials, data management and IT, or other. And if you have selected the other option, which I'm seeing about 6% of you do, please feel free to drop that answer in the chat feature for us to take a look at. Emily, it looks like just about everybody has responded. So I am going to end the poll and share these results with you. Can you see those?
I can see them, yes. Is the audience able to see?
I believe they can, yeah. So let me just
Okay,
read it aloud in
great.
case somebody's not there. We've got 35% saying that real world data is working with tokenized data, 18% outcomes research, 35% clinical trials, 59% data management and IT, and 6% at other. Thank you, everyone.
Great. Thank you all for your participation there. So part of why we wanted to ask that question was really to get back to the point I mentioned before kicking off the conversation. So, hearing a lot in the industry about needs around data access, we really asked ourselves at LexisNexis kind of how can we specifically help our customers solving their business challenges with relation to accessing data and tokenizing that data. And even more broadly than that, how can LexisNexis help the industry overcoming barriers related to tokenized data assets, data sharing, data integrity, a lot of questions that are kind of impactful, and putting it in the context of these cases for your teams is really helpful there. And those are similar, let me just navigate back here, there we go. Those are similar use cases to really what we've been hearing in our conversations. And what we really think is unique about some of those spaces, and I think comes into a position of being a little different than other industries is, what are the common requirements of those types of use cases? So in particular, customers in the healthcare space are focused on having a high level of confidence in the result. If we're tokenizing a set of data and individuals don't believe that there will be consistency in the token approach, they don't believe that they will have a strong ability to link records from disparate data sets, it's going to really lead to kind of crisis of confidence in that data and in the ways in which it can be applied, which is hugely important. We know that customers, in healthcare and in life sciences really need to consistently track the same patient over time. So anyone who is looking at outcomes, at efficacy, at real world data, being able to know that this is not just this patient today in this data set, but that if the same information is supplied, or even if the same patient is seen, I will be able to correctly link those records together over time. That is a huge part of the work being done within healthcare. And given all of the impacts on things like legislation, on approval for drugs and devices, it's hugely impactful to patients and to society to get that right. Similarly, kind of comprehensiveness. So being able to link together data on a single patient in order to understand what's happening to them clinically, what's happening to them in terms of other outcomes and events. Specifically here, I mentioned capturing of mortality is important because lack of that information can really skew research and results. But also exposure to things like social determinants of health, understanding kind of what are the pieces of that individual's life that are impactful outside of the clinical and medical experience. All of those really tie into these core use cases that you mentioned are kind of at play in your organizations. And I think it's really important to think about how that sets life sciences and healthcare apart from another industry like, say, finance, that could be using a kind of tokenization approach. So why do I bring that up? When we think about what is happening in the tokenization kind of industry today, we're talking about a computer science approach, right? Data in, hashes of information, tokens out. And there's intentionally limited transparency into all of the behind the scenes here because of the lack of information available. A life sciences company has access to their own clinical trial data, but if they're trying to link it to, say, a set of claims data, there's, because of HIPAA, good reason that there's not going to be an ability to kind of go back in and validate. Did all these records connect? Did they link the same records that I would have linked if I were doing this manually, et cetera? So without that transparency, we know that we have to accept a little bit of a gap, but this is kind of a scenario that could very easily happen today in the way that we tokenize data. So imagine, Jane Smith at 123 Main and born on January 1st, 2000, has a diagnosis of diabetes in a claims data set. And based on the tokenization algorithm, Jane and Janet Smith, both at the same address, both at the same date of birth, wind up coming out of the process with the same token. They're both token A over here on the right. But Jane and Janet Smith have two different diagnoses, and they also have, slightly different name, off by one letter. So you can see why something using, say, Soundex or character match or even first initial instead of whole first name would create that link. But it has an implication for research, for efficacy, that tells you if you think this patient has both conditions, you're going to be looking at them in a different lens. Interestingly, other records here below might also belong to Jane Smith, and they're not connected. Jane Smith at 123 Oak does not get connected, even though they share a date of birth, but now they're, Jane Smith is at a different zip code. So you can see that there are limitations, and for a long time, I think the industry hasn't necessarily known how to address those limitations and improve upon them. But one thing that LexisNexis can bring to the table is really leveraging referential intelligence that is unique in the industry. So understanding more about the variation of an individual's experience, their name, their address, the different kind of PII and elements that attribute to their profile as an identified individual over time, and leveraging that within a tokenization capability creates a really point of reference that is not available to others in the industry and not available when you are tokenizing and only comparing one record to another. You can see here in this table that it also results in an inherently different set of data points. So now 3 records wind up linked together from our table on the left with the PII into our de-identified table. All 3 of those records have the same condition, but we were able to track Jane Smith both when she moved to 123 Oak and when she got married and changed her name to Jane Jones. This creates a linkage over time that is really meaningfully impactful and creates a different opportunity from an evaluation standpoint. The idea that we now know Janet Smith is a different person and creates a different token, and a different record for Jane Smith at a different address and with a different date of birth comes through as yet a third token. This, considering that the tables here on the right are the ones that are typically accessible in the medical device or pharmaceutical use cases, you can see how it would lead to different research opportunities and different analyses. But how big is this problem, right? Oftentimes, I think you can see how it makes sense and you can kind of tell the story, but it might seem like it doesn't matter that much for your use cases because perhaps these are not that frequent of challenges. But I think understanding that the techniques that are used today, the computer science techniques, which are certainly advanced and powerful, still tend to be only as powerful as our observed data points. And the reason that matters is because of trends that are happening in society. We know that 40 million Americans move annually, and 5.6 million of those are out-of-state moves. Out-of-state moves almost inherently will create a disconnection in algorithms that are applied, partly because of the fact that a geography like zip code might be used in the token, or also because of the fact that individuals, as they move out of state, tend to move in and out of different health systems. So that creates different records that can have linkage challenges. In addition, 24% of US adults move within a 5-year period. This may not impact that much if all we care about is taking say, a 12-month snapshot and evaluating a certain, say, sales or marketing use case. But as we look at things like outcomes, efficacy, real-world data and evidence, understanding 5-year and beyond impacts is hugely important to the work that we're doing and has major implications on the results that we will see. In addition, we see 2 million marriages annually. That's not going to result in exactly 2 million name changes, but it is a pretty sizable population. And I think in the case of name change, there'll be even more challenged to create linkages across time versus even something like an address change. So I just made a note here about there are, again, kind of technical techniques and algorithms that are pursued to help get over some of the challenges we have. So, looking at things like Soundex, a technique to understand how close two records are together. So my name is Emily, E-M-I-L-Y, but if I were entered into the database as E-M-I-L-I-E, Soundex will be able to capture the fact that those two names sound alike and create that linkage, which is powerful. But in some regards, using techniques like these can also create what we call overlinking, or linking together records that are actually meaningfully different. An example of that really on the prior slide, Jane and Janet Smith. What LexisNexis knows about Jane and Janet is that they're actually twin sisters. I have twins myself, so I can say it would be very confusing if I named them only one letter apart. But in this example, the fact that they share a date of birth and they share an address in their history is going to make it challenging to differentiate between them meaningfully in analyses down the road. And finally, a note here about kind of variations in input PII. One of the requirements I mentioned in the prior slide is about the ability to have a high level of confidence that across disparate data sets, we will be able to bring data together. And in one data set, you might have access to different permutations of information. You have first name, last name, and address in one, but you actually have SSN in another. And that can create a need for different types of tokens to be built to bring records together. In a case where you have referential data at the center of your tokenization approach, we can kind of absolve a lot of those differences and increase the level of confidence in the match, even when the input information is different. There we go. A last note, because I think this is another really effective way to demonstrate kind of what is happening, is to consider the kind of patient at the center of a tokenization approach. The idea here being that what happens to the patient isn't only the information here on the bottom of this slide, right? The dermatology visit, the lab work, the biopsy, and the diagnosis, but what happens in their life. They have a change of address, marriage, they move. You can have access to things like the social determinants that create information and understanding around the life that they lead, around, who are their, how many dependents do they have in the house, and what are the challenges that might impact their ability to manage their own health. And finally, high level of confidence in our ability to capture those negative events, even something like mortality, to be able to thoroughly understand the view of the patient throughout the lifespan. So I think it's a really important thing to consider when you're looking through the lens of the life sciences use cases. As a pharma company or a med device company, you are going to have very specific and detailed information about really what's happening below the line in some cases, and limited ability to understand a lot of the activity above the line. And that's true of almost everyone operating within the healthcare space. So how can we leverage the information that we have to improve upon that and to drive improved outcomes? So lastly, I just wanted to leave you with a few kind of key thoughts about the kind of key principles to take forward as we consider tokenization and what makes a unique tokenization solution powerful in the healthcare space. So specifically taking a view on patient centricity, really how do we center the patient and their experience within healthcare and also within their lifespan as a part of the identification of a token. And that, I think, is both kind of a data approach as it is a healthcare approach. Next, enabling data augmentation and integration. How can we kind of leverage an approach that improves the ability to match across data sets, knowing that our silos of data are not going anywhere anytime soon, and we need to improve upon the ways in which we can integrate those and solve problems across several different data assets. Having a robust analytic engine. So going back to our de-identification discussion, any technique that obscures or generalizes data in sufficient way to be de-identified in nature is also going to make it challenging to have a detailed analysis of the data and really drive forward the analytics necessary for use cases in pharma, life sciences, and med device. So keeping that at the center of mind in terms of the context of why you're doing this is important. And lastly, secure and compliant. So we talked a little bit about the different kinds of not only tokenization, but anonymization techniques that can help to retain security and compliance based on even access within your organization. So taking a view of both how you can remain compliant with the healthcare legislation, but also how you can ensure security of sensitive patient information and reduce re-identification risk. So we wanted to make sure to reserve some time here for any Q&A and any discussion among the group. And we also, before Brooke kind of pops in, wanted to mention that we'll be having some subsequent conversations. So please stay tuned to LexisNexis and Q1 for updates on the next scheduled events.
Thank you so much, Emily. Really informative presentation, and thank you so much to our participants. We have saved time for Q&A. I've seen a few questions come through. Please continue to submit those within the Q&A function, and I do encourage you to be as specific as possible. I know we've got varying levels of knowledge on this, so please feel free to include an example or reference back to a particular area within the presentation to better assist Emily in thoroughly answering those. And as Emily mentioned, this is just the first in our series of webinars. It'll be taking place later this fall into the end of the year. And we wanted to get your feedback. Again, looking to just see who would like to potentially be pre-registered for the upcoming events. We'll be sending out a survey later, of course, to get everyone's feedback on today's presentation, but I'm going to quickly launch this poll, again, just to see if anyone would like to be pre-registered for the next 2 webinars in our series. We'll save you some time and can take care of that for you. Again, if you don't, please just feel free to answer no within the poll, but I will leave this open for just the next few seconds to give everyone a moment to answer, and I'll close it and then we'll jump right into Q&A. Again, please feel free to follow LexisNexis or Q1 Productions on Twitter and keep in touch with us. Thank you everyone for responding. I see we've got about 60%, so I'm going to close this off in just the next 10 seconds. Again, if you'd like to be pre-registered for the next 2 webinars in our series, please just click yes or no. We'll be in touch with those dates and topic areas in the coming weeks. All right, I'm going to close this off. Thank you so much, everyone. Let's jump right into Q&A, Emily. First question that came through, this is a longer one. I'm going to read it back to you here. In reference to slide 17, how does patient-centric referential intelligence compare with probabilistic linkage methods such as those described by Duke University to link patient records in study registries with claims data? So that's the first question. Second question being, what factors play into the referential intelligence, I hope I'm saying that correctly, and how transparent and reproducible is the method, particularly in the context of using tokenized data to support regulatory or payer submissions? Great question here. And Emily, please, we welcome your feedback.
Yeah, thank you, Stuart. That's a really excellent question here. So I think one thing I was not particularly clear about, and I really do appreciate the opportunity to add clarity, is that the referential intelligence that is referenced in that slide is not a method or a kind of technique, but it is actually leveraging referential data on individuals that LexisNexis has built over 40 plus years of experience in the industry. So what I mean by that is, there's obviously many methodologies behind the scenes to leverage that data, tokenize it, and maintain high levels of data security and compliance. But the intent is to be able to say, this is not a probabilistic method by which we presume that we have a high level of statistical accuracy that these 2 things are linked, but that we have actually observed based on our collection of public records, credit information, all of the information that is accrued to really ensure that we can say that we know these things are linked together. So what I mean by that is My name is Emily Mortimer. I live in Minnesota right now, but just a year ago, I lived in Pennsylvania, and several years before that, I got married and changed my last name to Hofer, from Hofer to Mortimer, excuse me. And in the process, created records along the way that identified me with those different combinations of names and addresses. And those are coming in through various records and attached to a single known data point in an identified fashion. And leveraging partnership with data vendors and expert determination from a de-identification standpoint, a process has been put in place that allows us to leverage that in a de-identified fashion so that the connections we're making are not probabilistic, but they are actually observed. So I think it's just kind of a fundamentally different approach. And when you think about the reproducibility, I think the method is certainly reproducible. What is unique about it is kind of the data that undergirds the method. So where you could have access to that type of a data asset and how accessible that would be is probably the limiting factor in reproducing a technology like this. So hopefully that was sufficient there. Do you want to move on to the next question?
Thank you so much for that, Emily. Yes, and thank you for the questions. Moving right along, another question: has tokenized or tokenization, I'm sorry, been introduced in the EU? If so, is it consistent with GDPR?
Thank you, Brian. That's a really great question. I'm going to also go ahead and acknowledge that I'm probably not the most expert as it relates to European and UK policies here. I am aware of conversations in which there is interest in understanding how to safely and securely share data. I think those conversations become complicated in countries for whom the healthcare data tends to be centralized because of government payer healthcare access. So, there's certainly different complexities and restrictions there that I'm not wholly familiar with. But I do believe that, the way that GDPR has been written, there is going to be a need to comply with that. But similar to the US, I think the restrictions around healthcare data are even more limited. So it's not just mandated by GDPR. But I will certainly acknowledge that there are European experts out there who are much better placed to answer that question. But thank you for sending that in.
Thank you so much. And last question we have here, and we do still have a few minutes, so feel free to submit any last ones that you have. How do you ensure the appropriate consents or authorizations are in place prior to linking the data? Great question.
Yeah, thank you, Terry Ann. This is a great question. So, one of the things that I mentioned earlier in the presentation and probably could have expanded on a little bit is this idea around kind of what it means to be considered a covered entity versus having a BAA in place. And tokenization, to the way that it impacts healthcare data tends to be sort of the flip side of that. So if you are a health system, or if you are, in the cases of most of the members of this audience, right, if you are a medical device company, you probably have covered entity perspective on data for patients for whom one of your devices was implanted, for instance. But that doesn't necessarily mean that you have the ability to share that data in any kind of other capacities or for other use cases at your organization, or that you would have access to other data on those individuals. So at least today, the way it's largely interpreted, the de-identification requirements are intended to be used for anyone outside of that covered entity BAA umbrella. And what that really implies here is that consents and authorizations from the patient would not be required, because we're talking here about maintaining de-identified data such that it does not risk the patient's identity being known, and it can be managed under the de-identification standards of HIPAA rather than under the covered entity and BAA standards.
Thank you so much for that. We do still have time, so if there's any further questions, please do drop them in the Q&A. Again, as mentioned, this is the first in a series of 3 webinars that we'll be developing on tokenization, so please be on the lookout for further details to come on those. I'm not seeing any further questions come through. Emily, any last remarks before we lock up?
I just wanted to add one thing to kind of Terry Ann's comment as I think about it. So the other piece I think that really is important for all of us leaders in the industry to be thinking about is how to be responsible with that data. So we know that it doesn't require patient-specific, consent, even in a de-identified fashion. But we as an industry can lead the way in ensuring that we are using the information in a way that improves patient experience, generates increased trust rather than distrust or mistrust, really focusing on, the use cases you all mentioned in outcomes and efficacy and real world data. Those are really use cases that positively impact patients' lives. And I think if we take the approach of feeling responsible for that data, it'll be a meaningful part of making progress toward patients being more comfortable with, having the data used in different ways.
Sure. Thank you so much for that. Appreciate that clarification, and appreciate again all of you being with us today. Once we get off the line, I will be in touch with a survey, and I'm going to be sharing that feedback with our team at LexisNexis and Emily. So please be on the lookout for that. We do always appreciate your feedback, and I'll also be in touch with a copy of today's presentation recording, which I'll be sending out. So thank you again to all of our attendees for investing your time with us today. Truly cannot thank the fantastic team at LexisNexis Risk Solutions enough. Pleasure working with you guys, specifically today's presenter, Emily Mortimer, who's the Director of Strategy at LexisNexis Risk Solutions. Thank you so much, everyone. We look forward to seeing you back in our next webinar in our series. Be safe and be well. Have a lovely rest of the day. Bye-bye.
Thank you.